Good morning, everyone, once again. Today, we have to introduce a quite new topic of anatomy, and this is about lymphatic drainage of the limbs of the breast and the surface of the trunk, and their clinical importance. The lecture is divided into two main parts. I invited a clinician, Dr. Schmidt, who will introduce her clinical work by introducing interesting cases to demonstrate how important the lymphatic drainage and the question of the lymph nodes is. This is the second part of the lecture. I will start with a short anatomical summary, what you definitely need for the exam, and those clinical aspects will be highlighted by Dr. Schmidt in the second half of the lecture. Let's start because the time is flying. First of all, I have to tell you some basic terms. What are the lymphatic organs? What is lymph fluid? And some basics about the lymphatic circulation. And then I will talk about lymph nodes. I just mentioned the great lymphatic vessels without going into details because that is a more second semester issue. And I have some slides about the limb, the breast, and the trunk and the lower limb. As you will see. If you compare this material with the list of exam questions, you will find a topic which is related to this. So in the second semester, we will talk more detailed about the lymphatic system. I just define it now that the lymphatic system is a defense system that should protect the body against possible pathogens, viruses, bacteria, parasites, and sometimes even foreign bodies or even cancer cells should be eliminated by the lymphatic system. It has many parts, and what I would like to talk about today is more briefly the lymph fluid. I will talk about lymph vessels, and I will talk about lymph nodes, which belong to the lymphatic organs already. And there are many other lymphatic vessels which are not highlighted today. They belong to a later course, like tonsils, the thymus, the spleen. We do not discuss today, but we will focus on the lymphatic vessels and the lymph nodes in this talk. So what is lymph fluid first, and what do I have to know about this? First, you probably know already that we have arteries and we have veins in the human body, and these vessels are interconnected by capillaries with each other, and the blood is pumped from the arteries into the capillaries, and finally it is drained into the veins. The vascular wall at the capillary level is not completely sealed because there is a certain amount of fluid transported from the vessels into the extracellular space. It's kind of filtered through the vascular wall, and this fluid is then finally returning into the venous side of the capillaries, into the veins, but not completely. Few liters a day stay outside the blood vessels in the extra vasal space, and this has to be collected. And these green highlighted vascular structures are the lymph capillaries. They will pick up this fluid to drain this away from the tissues. And this lymph capillaries will transport this lymph fluid into the lymph nodes. In this scheme, you can see the same thing. So arteries, veins we have. This is the heart, which keeps the circulation in motion. And then at the cellular level, the extra vasal space is filtered, and it's the extracellular fluid is collected also by the lymph capillaries, which pass through lymph nodes, and you will see that the lymph circulation finally returns into the venous circulation. This point where the lymph fluid returns to the venous circulation is found on the neck area in the venous angles. I will come back to this point a bit later. Important is to know that the lymph nodes will drain the lymph fluid from a certain body part, and therefore these lymph nodes are responsible for that particular area of the body. Therefore, we use the term primary or sentinel lymph nodes for those which are responsible for a particular body part. If we would like to check how is this lymphatic vascular system organized, on the limbs, one can find a system of lymphatic vessels running quite close to the skin subcutaneously. They could be defined as the superficial lymphatic vessels, and in the deep, next to the vessels, the arteries and the veins, the larger vessels of the limbs, there is a second system of lymphatic vessels which we call deep lymphatic vessels. They will transport also the lymph fluid. Importantly, the lymphatic vessels have valves inside, and based on the motion of the muscles and the pulse of the arteries, these valves will then direct the flow into one possible direction upwards, and this pumping function supports the circulation of the lymphatic fluid away from the limbs. If we go on with the lymph nodes, I mentioned already that we have certain body parts, and let's take this hypothetical body area. Let's call it drainage area 1. We have a lymph node which is responsible for the lymphatic fluid collection for this particular body part. This is the so-called primary or sentinel lymph node. And then the lymph fluid is filtered in this lymph node, and from this lymph node, the lymph vessel exits, which will enter a secondary lymph node, which filters the lymph fluid again. And what I wanted to explain you in this scheme is that sometimes even a third order lymph node group exists as well. One may call them tertiary lymph nodes. If a disease is coming from this drainage area and affected the first lymph node, you know that the lymph node is sick. Sometimes the secondary, and in worst case, even the tertiary lymph nodes might be also inflamed or may be affected by the disease, and this is related to the severity and the prognosis of the disease. Another point, what you shouldn't forget, that secondary lymph node, for example, this secondary lymph node is in relationship to this drainage area 1 is a secondary lymph node, but the yellow indicated lymph node might be at the same time responsible for another drainage area, which it is the primary area in relationship to this lymph node. So one single lymph node might be both primary and secondary, depending on the drainage area we are examining. And of course, the story is highly complex. You can imagine all kinds of combinations of these, but several drainage areas are in the human body, and we have therefore primary, secondary, and tertiary lymph nodes. But this this brown or dark yellow lymph node would be the tertiary lymph node for the first drainage area, but it's the secondary lymph node for the second and for the third drainage area. So you can imagine that this is a quite complex system. Dr. Schmidt will explain you the significance of the primary lymph nodes in her part. After these secondary and tertiary lymph nodes, the lymphatic vessels will already continue towards the large lymphatic vessels, and I will come back to this point. About lymph nodes, you have to know that they are usually quite small structures. They are sometimes 1-2 centimeters large, but these are already big ones. Usually they are not larger than few millimeters. They are bean-shaped organs. They have a capsule, and they are made up by lymphatic follicles. More details I don't want to tell you today. It's related to the histology 2. I will give you some lectures on that next semester. And then we have as I mentioned, the lymph nodes, which have a filtering function and also immunological functions. And the clinical point of view is that if you examine a patient and the patient complains about some sensitive areas, some sensitive lymph nodes, you also have to examine those. And if you have an inflammatory disease, for instance, here in the lips, then the inflammation will cause here, for instance, enlargement of lymph nodes in the submandibular area. If they are sensitive, if they are easy to move, and if they are enlarged and soft, one has to expect inflammatory disease. However, if you have a patient who has cancer and the tumor is developing in the lymph nodes, then usually the lymph node is not painful anymore. It is much harder, and you cannot really move it from away from the surrounding tissues, because the cancer tissue may grow around the lymph node into the surrounding tissues and fixes the lymph node to those. So this is a clinical issue what you will see, and you can already distinguish, or at least you can imagine what could be the problem with the lymph node, and this gives you an idea how to continue with the diagnostics. And as I mentioned, we have these great lymphatic vessels. So after filtering the lymph fluid in the secondary and sometimes tertiary lymph nodes, larger lymph vessels are formed, which are fusing with each other. The largest one is the so-called thoracic duct, and that drains into the neck area, into the so-called left venous angle, and it picks up a couple of lymphatic vessels. I listed the names here. Cisternachili is this enlargement, and then we also have the subclavian trunk, we have the left jugular trunk, and we have the bronchomediastinal trunk. But these detailed lymphatic vessels are not required for this exam. It's just listed here to understand that the half of the head, the left upper limb, the lower half of the body, and the left half of the thoracic cavity is drained into this thoracic duct, and right and top to this border, the lymph fluid is drained into the so-called right lymphatic trunk, which picks up the corresponding lymphatic vessels on the right side, subclavian, jugular, and bronchomediastinal trunks, and then they fuse to form the right lymphatic trunk. And these vessels, the thoracic duct and the right lymphatic trunk, will drain into the venous angles, because here is a quite low pressure. There is a certain sucking force here which will provide a certain energy to drain the fluid from the entire body. And in the second semester, if we dissect the torso, you will see that after the removal of the thoracic organs in front of the spine, one can dissect this thoracic duct which drains the fluid towards the left venous angle. We will come back to this in the next semester. When you are preparing for the exam, don't waste your time with the details on the large lymphatic vessels. I just mentioned them in order to make clear that the lymph fluid returns into the venous circulation finally. And if I go on, then what I have to point out is the lymphatic drainage of the upper limb and the breast. So if we study the upper limb, we have lymphatic vessels arising on the hand, on the palm. They turn between the fingers to the dorsal side of the hand, and they are traveling upwards under the skin. And they like to follow the superficial veins. In the cubital fossa, in the elbow area, we already have some cubital lymph nodes, which then continue to the so-called lateral axillary lymph nodes, which are in the groove just under the skin of the armpit. Under the skin, these lymph vessels travel. If they get inflamed, one can see as a red stripe on the skin. This is an infected lymphatic vessel called lymphangitis. This is sometimes visible if the patient has skin infections. The lymphatic drainage of the breast is the next point, and this is maybe the most important part of this lecture today, because the breast, unfortunately, is affected in ladies quite commonly by cancer, by tumor, and this kind of cancer, breast cancer, may spread along the lymphatic vessels as well, and they may cause lymph node disease as well. So I have to explain you then here the lymphatic drainage. I mentioned that the upper limb is drained mainly into the lateral axillary lymph nodes. And then from the female breast, the lymph fluid is drained into the lymph nodes on the chest, called pectoral lymph nodes. Then the secondary group to this is the so-called subscapular lymph node group, which is then secondary in relationship to the lower lateral part of the breast. The medial part of the breast is drained to the lymph nodes situated right behind the chest bone, the sternum. That's why you call these nodes parasternal lymph nodes. And from the upper lateral quarter of the breast, the primary lymph nodes are situated in the central group of the axillary lymph nodes. And importantly, please note that the central axillary lymph nodes will get the lymph fluid from the pectoral, subscapular, and from the lateral axillary lymph nodes as well. So they at the same time are secondary to these areas and primary to the upper lateral quarter of the breast. Also, some lymphatic vessels go straight into the apical axillary lymph nodes, which are then the tertiary nodes, since this lymph fluid has been filtered already once here and the second times there. So these are the directions from the female breast. This is a quite complex anatomical description, as you can see, but you have to study this for the exam. Also, one more remark, that the lymph nodes down there in the pectoral lymph nodes may even communicate with the lymphatics of the abdominal cavity. So this is also not unimportant for the spreading of the disease. Surgeons don't go into those nomenclatures, but they use 3 zones most of the times to define the prognosis of the disease if these lymph nodes get sick also. You have here the pectoralis minor muscle, and this pectoralis minor muscle as a reference structure. Lateral to this, clinicians define the zone 1. Between the muscles at the level of the pectoralis minor muscle is the second zone defined, and above medially to the pectoralis minor one defines the third lymph node group. And the more lymph nodes are affected by the disease in the higher areas, higher zones in the second or in the third area, the more likely it is that the disease has spread far and the prognosis is getting worse and worse, as you will see in your clinical practice. After the lymphatic drainage of the breast, I would like to show you a slide about the lymphatic drainage of the trunk. This is quite simple. Here you can see the border around the belly button. So above this border, if you follow the course of these lymph vessels, they drain into the axillary group, into the superficial or lateral axillary lymph nodes. And from the down to the belly button, the lymph vessels will travel down to this group of lymph nodes, which we call superficial inguinal lymph nodes. So please note that the border is around the belly button, and above we drain into the axillary, and then below the fluid drains into the inguinal nodes. This is to the skin-related lymphatic drainage mainly. And finally, before I give further to Dr. Schmidt, I would like to tell you the lymphatic drainage of the lower limb. The lower limb has lymph nodes which are situated mainly in the inguinal area next to the inguinal ligament. And if we compare these two figures, this one is a posterior view, and it shows the sole of the foot, the plantar region. And this here shows an anterior view with the dorsal side of the foot. Now, please note that the lymph vessels start on the sole. They turn between the toes onto the dorsal surface of the foot, and they will then travel along the greater saphenous vein, which is a larger superficial vein of the lower limb. On the other hand, some lymph vessels will follow the lesser saphenous vein, and those which do that will drain into the popliteal fossa, which is a groove behind the knee. And there are lymph nodes called popliteal lymph nodes. They will then pick up this lymph fluid. And then if we return to the anterior side, you will see that the lymph nodes in the inguinal area will pick up these lymphatic vessels, but not only the front side of the lower limb, but several areas also belong to this group. And please note the list here. This is absolutely required in the exam. So if the question arises, what areas are the superficial inguinal lymph nodes responsible for, then you have to know that if one finds here enlarged lymph nodes, you have to check the ventral side of the lower limb. You also have to check the back side, the gluteal region. As I mentioned, the abdominal wall has to be studied if there is something wrong, maybe. Then also the external genital organs are draining their lymph fluid here, and sexually transmitted diseases start here many times, and they cause typically first enlargement of the inguinal lymph nodes. Pelvic floor, perineal area, anal canal also belongs to the area. In ladies, the vagina, lowermost part of vagina, is also drained to this. So if you find enlarged lymph nodes, you have to ask your patient to visit a gynecologist also. And the uterus may come into question. There is a certain little area of the uterus next to the fallopian tube, the so-called tubal angle, which may carry some lymph fluid into this area, so that has to be checked also. So this is the checklist what you have to examine if you see superficial inguinal lymph nodes to get a diagnosis. Why is this lymph node group enlarged? One can divide the inguinal lymph nodes into a superficial and into a deep group, and the superficial one has a subgroup that is along the inguinal ligament. This is called horizontal tract, and along the greater saphenous vein one can define a vertical tract. The lymph fluid goes from these superficial lymph nodes into the deep, and this deep lymph node group is the deep inguinal lymph nodes called Rosenmüller's lymph node, which is the final one on the free part of the lower limb. From here the lymph fluid is drained already into the pelvic area, into the abdominal cavity, and then this disease, if this lymph node is inflamed, spreads further. This is an example for an inguinal lymph node inflammation in a patient who suffers on some kind of sexually transmitted disease. Okay, we are at halftime now, so I would stop now, and I will give the floor further to Dr. Schmidt, who will go on with her clinical cases. Just a moment, I will stop sharing, and Dr. Schmidt, please go on with this.
Good morning. Thank you for the possibility. I am really glad that I can demonstrate you the lymphatic system by the help of nuclear medicine. Nuclear medicine is one of the most interesting fields of medicine. We apply radioactive isotopes for diagnostics and therapy. These are functional methods. That means that we can see only the functioning structures. The lymphoscintigraphy works the same way. Technetium-labeled colloidal particles, denatured albumin, is used for lymphoscintigraphy and will be injected intra or subcutaneously in a few small portions. Because of their size, that means 20-30 nanometers, the particles will be transported through the lymphatic vessels into the lymph nodes, where they will undergo phagocytosis. They will be phagocytized by the MPS cells of the lymph nodes. With the help of some patients, I would like to demonstrate you how it works in clinical practice. Our first patient had a swollen lower limb on the left side. Ultrasound and angiological examinations excluded the thrombotic origin, and the question was whether the edema was lymphedema. The technetium-labeled colloidal particles, nanoalbumin, were injected into the interdigital spaces of the feet bilaterally. And here you can see the lymphoscintigraphy of both lower extremities. Early and delayed scans were performed. You can see actually colorful strips and spots, which represents the lymphatic vessels and the lymph nodes. For better orientation, I enclosed an anatomical schema. This lymphatic vessel on the left side you could see here, and on the right side here. You can see small crosses. These are markers which help in the localization. In our case, we found bilateral good flow. In the early phase, you can see the inguinal lymph nodes, and the flow, the lymph flow, is on the left side quicker. So in this our finding supports rather the venous origin of the edema. The next patient had a urogenital tumor, therefore an operation, and during the operation, the inguinal lymph nodes were removed. That means that the patient had inguinal lymphadenectomy. After the operation, complication occurred, leakage of the lymph in the left inguinal region. For therapy, a lymphovenous anastomosis was performed. That means a shunt between lymph vessel and vena, and the question was whether the anastomosis works. The lymph flow is excellent. The liver activity appears in the early phase, and this is a sure sign of a functioning anastomosis. The lymph, via the anastomosis, flows into the blood, and from the blood into the Kupffer cells of the liver. The third patient had bilateral swollen lower limbs, and on the left side an enormous lymph sac, so-called lymphocele. Here can see here the enormous lymphocele. The origin of the edema was partly venous, partly lymphatic. The patient had varicosity, and because of an earlier bacterial infection and inflammation, erysipelas, and the lymph nodes were damaged on the left side. For therapy, a lymphovenous anastomosis was performed in this case too, but in this case, the surgical intervention was inefficient. The anastomosis didn't work. In the early phase, you can see really nothing. There is no liver activity, not even 3 hours after the injection. You can see crooked, coiled lymph vessels indicating the disturbed lymph flow. The fourth patient had bilateral breast cancer, therefore mastectomy, and axillary block dissection on both sides. That means that the axillary lymph nodes were removed. She had swelling in both upper limbs, which was on the right side more serious. In this case, the radiopharmaceutical was injected subcutaneously, bilateral, into the interdigital spaces of the hands. Early and delayed images were performed. In the early image, you can see only the lymphatic vessels of the forearms here. This cross represents elbow, and this cross represents wrist. So this is the forearm, the region of the forearm. And in the early phase, we can see 2, 3 small lymph nodes in the left cubital region too. On the right side, we can see only the lymphatic vessels and the relatively high background activity. After 1 hour, you can see a lot of lymph nodes in the left cubital region, and a few 3, 4 lymph nodes appears in the axillary and infraclavicular region too. On the right side, you can see a high diffuse activity in the region of the upper arm and lower arm and forearm, and 3, 4 lymph nodes in the axilla and the infraclavicular region. These scans represents bilaterally disturbed lymph flow with dominance on the right side. These lymph nodes, these aforementioned lymph nodes, can be localized to the indicated areas in this schema here. The greatest clinical importance among the nuclear medicine methods in connection with lymphatic system has the sentinel lymph node scintigraphy. The spread of some forms of cancer usually follow an orderly progression, spreading first to the regional lymph nodes. The tumor cells appear at first in the first lymph node belonging to the tumor, and the principle of sentinel lymph node scintigraphy is that the route of the particles is the same as the route of the tumor cells. After a peritumoral injection of labeled colloidal particles, the first lymph node belonging to the tumor will be represented. This is the sentinel lymph node. For sentinel lymph node scintigraphy, we use larger colloidal particles. The particle size is between 100 and 600 nanometers. These large particles remain for a long time in the sentinel lymph node, so they are detectable even 24 hours after the injection. The sentinel lymph node will be preoperatively labeled, and during the operation, with the help of an intraoperative detector, so-called gamma probe, removed. Here you can see this device. In the top of this device is a small scintillation detector, and on the other hand, on the other end, you can see the count rate of the labeled sentinel lymph node. So the sentinel lymph node will be removed with this detector, with help of this detector, and after the removal, it will be examined by histology. If the histology of the sentinel lymph node is negative, the radical block dissection is unnecessary. The indication of sentinel lymph node scintigraphy is the clinically negative regional lymph node state. It has significance in the operation planning in patients with early tumor stage in avoiding unnecessary block dissections. It is suitable, usable only for the detection of small or micro metastasis. If the lymph node has lost its whole function because of the metastasis, the detection this way isn't possible. The sentinel lymph node scintigraphy is most frequently used in malignant melanomas, breast cancers, and in genital tumors. This is a sentinel lymph node scintigraphy in breast cancer from anterior and right lateral view. This cross represents axilla. On the lateral side is this axilla, and on the anteroposterior projection, the second cross represents ugulum. The large spot is the peritumoral injected activity, and the smaller spot is the sentinel lymph node. You could find this sentinel lymph node in this region. These are sentinel lymph node scintigraphy in malignant melanoma of the back from antero-posterior and from right lateral view. 1 hour after peritumoral injection of the radiopharmaceutical, you can see an intensive activity in the right axillary region. In the early phase, you can see the lymphatic vessel 2, which is leading to the sentinel lymph node. You could find this sentinel lymph node in this region. For presentation of pathological lymph nodes, spatial techniques are available. For example, 131 iodide accumulates in differentiated thyroid tumors in papillary and follicular thyroid carcinomas. And not only in primary tumors, but in metastasis too. Or adrenerg or somatostatin receptor scintigraphy are helpful in the detection of neuroectodermal or neuroendocrine tumors and in the detection of their metastasis too. This is a whole body scintigraphy, anterior and posterior view after 131 iodide therapy. The patient had papillary thyroid carcinoma. You can see an intensive pathological accumulation in the chest on the right side. This accumulation of salivary glands and mouth is physiological, is normal. Using multimodality, hybrid imaging technology, combined imaging device, that means a transmission CT and a SPECT, single photon emissions computer tomography in one instrument, we can localize the pathological accumulation in the right hilar mass. It is a pathological lymph node of the papillary thyroid lymph node metastasis of the papillary thyroid carcinoma. It's really a fusion of morphological and functional images, which allows a correct diagnosis. It's more sensitive and more specific than only transmission CT or functional image. The next patient had follicular thyroid carcinoma. After iodide therapy, the whole body scan from anterior and posterior view. You can see on the right side circumscribed accumulation and diffuse high activity in both lungs. With the help of SPECT CT scan, we can localize the circumscribed activity in the mediastinal lymph node, and the micro and the diffuse high activity in the lungs is due to micronodular metastasis in both lungs. You can see these small spots which are the micrometastases of follicular thyroid carcinoma. This is an adrenal receptor scintigraphy. The injected radiopharmaceutical is 123 iodide MIBG, methiodobenzyl-guanidine, which binds to the adrenal receptors. The patient, it was a child, was operated on neuroblastoma, which is a malignant neuroectodermal tumor. And on the SPECT CT scan, we can see pathological accumulation in the left para-aortic region and an enlarged lymph node metastasis, confirming the metastatic disease. This small accumulation is in the area of injection. It's not pathological. You can see a physiological liver activity, and you can see a physiological urine bladder activity, but this intensive accumulation is the pathological lymph node metastasis. It's a somatostatin receptor scintigraphy. The patient had carcinoid tumor in the pancreas, which was removed, and with the help of somatostatin receptor scintigraphy, we can detect and involve lymph node metastasis in the root of mesentery, in the mesenteric radix. This is a FDG PET scan, it represents glucose metabolism. A number of malignant tumors show a high glucose metabolism and glucose accumulation. For example, non-Hodgkin lymphoma, which is a malignant hematological disease. In the whole body scan, you can see supra and infradiaphragmatic, cervical, axillary region, and para-aortic region, both parailiacal region, pathological lymph nodes with high glucose utilization. These are manifestations of the malignant hematological disease. So I hope I could demonstrate you that the lymphatic system exists and works, even you can't see these small vessels and nodes during your anatomical studies on the bodies. And I hope that I could demonstrate you that the anatomy of lymphatic system is very important in the clinical practice too. Thank you for your attentions.
I also thank you for your talk, and I also thank for your attention. We recorded the lectures and we will load it up as always. Thank you very much, and have a nice day.